The government launches its National Cancer Plan today, and it's all about trying to get people to be seen faster, slashing waiting times, investing more money in new tech, and entering what's been described as the postcode lottery of patient care.
I got a chance to catch up with Professor Peter Johnson, who's the National Clinical Director for Cancer at NHS England, and I got his thoughts on the government's plan. What do you see as the main aim of the government's cancer plan?
So what we need to do is capitalise on where we've been doing well. Survival from cancer has never been higher, but there's also a sense that progress has slowed in the last few years, and certainly as we all get older and as more people get cancer, so we need to make sure that we're responding to the pressure in the system and make the most of things like modern technology, AI, digital capabilities to deal with the pressures that are coming through.
I guess none of those things are that new. So why has it taken this long to be announcing this plan?
The cancer plan is something that we've been renewing every 10 years or so, and we've been working to a previous plan in the NHS, the long-term plan, which focused very heavily on the early diagnosis of cancer. Now, that's a focus that we need to maintain, but we're also aware that things are changing. The world is changing in the way that we use AI, for example, and can use that to speed up diagnosis and to help make the most of the workforce that we've got. Lots of changes in the digital world as well, using the NHS app to contact people to make sure that we can make them aware of trials, for example, that are available for them. So we need to flex the plan at the same time as really maintaining the focus on preventing people from dying from cancer, which is, of course, the headline ambition.
Do you think that there's been a change in sentiment along with the change in government towards cancer in the NHS?
I think the focus on improving cancer and investing in the NHS has probably become stronger in the last year or two. We've started to see improvements. We've really struggled to hit our cancer waiting times, and there's been a historic level of underinvestment, particularly in diagnostic services, things like scanners and radiologists to read X-rays. And we've started to reverse that. A huge amount of money has gone into community diagnostic centres to make these services more widely available.
You mentioned waiting lists. Clearly, that is an area where everyone's aware we've disappointed. You kind of framed some of the areas as doing relatively well, but do you accept when most international comparisons, particularly in the last 5 or so years, we haven't done so well on cancer metrics?
Our survival figures continue to improve, and in many areas we're actually catching up with people internationally, but also there's a recognition that we have much further to go. I think all healthcare systems, and if you look across Europe, it's the same in many different countries, everyone is struggling to cope with the fact that we're all living longer, which makes us more likely to get cancer, which means that there are more people who need to be diagnosed and treated. And what we need to do is work out where we can grow most rapidly, where we can really put the resources in to make a difference.
The plan wants to get a 5-year survival rate up to 75% by 2035. Where is it now? And with the pace of improvement that you're alluding to and all sorts of medicine and technology, might we be able to overshoot that? Might we be actually undershooting?
I think getting to 75% of people surviving 5 years or more after a diagnosis of cancer by 2035 is a pretty stretching ambition. We're at about 55 to 56% from the last cohort we've got data on, which is from 2016. That will undoubtedly have increased in the last few years, but we know that it's going to be quite stretching. We need to keep focusing heavily on diagnosing cancer as early as possible because we know that's what makes the biggest difference. If we can catch cancer at an early stage, then that improves the chances of surviving it more than anything else.
Is AI going to help with that?
AI can help us to make the most of the expertise that we've got available. So using it as part of the diagnostic process, helping people to read CT scans faster. We've seen data coming up about mammography, for example, using AI instead of a second radiologist to look at mammographic scans can maintain the quality but obviously reduce the workload. So finding ways to streamline the processes that we've got going on at the moment is probably where AI is going to be most helpful.
And in terms of where those streamline abilities or optionality exists, you mentioned waiting lists. Is that the main area, or are there more complex down the line aspects that could deliver great rewards?
So about 3.3 million people were referred for investigation of possible cancer in England last year. And what that tells you is that there's a huge number of people for whom we need to have diagnostic tests available and have to give them the answers to those as quickly as possible. That puts a huge pressure on our expert workforce, whether it's radiologists looking at CT scans or histopathologists looking at biopsies. And what we want to do is give them the tools to work as rapidly as possible to make sure that we meet the demands that our ageing population is putting on the system.
Clearly, across different regions, there are different results in all parts of the NHS, but I think it's very stark in cancer treatment. The least deprived, the most deprived areas of England see the stage of diagnosis much, much worse than in richer areas. How is this plan going to address that?
Tackling differences in stage of diagnosis, expertise of treatment across the country is a really important part of this plan, driving down on inequality. One of the areas where we've seen big progress on this, for example, is in the diagnosis of lung cancer, where our lung cancer screening programme has been targeted at those communities where smoking rates are highest, people's chances of getting lung cancer are highest, and the rates of late diagnosis are highest. By doing that, by focusing our screening programmes into those areas, what we've seen is that we've reversed that relationship. So people in the poorest areas are now more likely to get their lung cancer diagnosed early because we've focused the resources on dealing with that particular problem.
Just finally, Peter, sort of question slightly stepping back from all of this, but your views towards the NHS structure overall. There's been talk of need for reform, and different governments over the course of this century have gone back and forth about employing permanent leadership that doesn't change with a changing government versus the government minister needing to have more authority and control again. Where do you stand on what works best?
I think what works best is having a plan that is relatively long-term, that allows you to manage the system not just for this year, but for a decade, that gives you a stable structure so that people know who's going to be delivering the care. We have Cancer Alliances, which is a network of organisations across the country who've been doing a fantastic job in the last 5 years, helping us to improve early diagnosis, helping to improve survival. And I'm delighted that they're part of this plan going forward, because what that tells you is we've got a stable structure for delivering this change. We've got ring-fence funding, £200 million for them next year, to make sure that we can deliver the things that we need to do on the ground.
Peter, thanks so much for joining us. We really appreciate it.
It's a pleasure.